This is Charles Denham, and I'd like to welcome you to our May 18th webinar, and we're very excited to have a very hot topic and one that most people are very, very interested in. However, I want to cover just a couple of housekeeping details. Please make sure that your WebEx volume on the software of WebEx is up at the very max, and that your audio volume is up for your external speakers, or your speakers for your computer are all the way up, and that will help you make sure that you get good audio coverage. Now, on slide 4, for those of you that have slides, please take a look at what you need to do if you need to get a better line for audio. And what you do is click on the participants icon and then the small request phone icon in the lower left corner of your screen. For those of you that don't have the slides and don't see that, it's the participants window and then the left lower corner of your screen that you'll see it. On slide 5, we have our Safety Leaders website. It's a little different right now. That, with all the things that are going on the internet right now, we're just transitioning over to a different platform. And you'll see Sepsis, the Basics, Part 1, and you'll be able to come back and actually get a new set of slides when Dr. Jeanne Huddleston is able to speak. Unfortunately, her mom was admitted to hospital last night. She's in the ICU, and Jeanne is on a plane flying to be with her family at this time, and we all understand that. And so Jeanne will have a short introductory section to the full session today, and you'll be able to come back to see that. And that's on slide 5 of the slides, where you'll be able to come back and see them. On slide 6 are the social media addresses and tags, and on slide 7 is the TMIT purpose statement. Our purpose is we'll measure our success by how we protect and enrich the lives of families, patients, and caregivers in this area of sepsis that we're covering today. Very critical for both. Our mission is to accelerate performance solutions that save lives, save money, and create value in the communities we serve and the ventures we undertake. Our disclosure statement is there. There are no disclosures of any product, service, or technology that will be covered today. And we have Dr. Jeanne Huddleston up as a speaker, who will introduce Dr. Arnold in our on-demand version for today because she's had a family emergency. She won't be speaking, and I'll cover a couple of topics. Pardon me. And so I'll kick off right away. Our first topic is focus on in the news and national survey highlights. This is our update, and the update from our last 2 months' webinars. The first is that ProPublica has recently, as of May 12th, undertaken an article to address the escalating rise in maternal mortality at the time of delivery, and this is going to be a hot topic. Pardon me. I've been suffering from the virus that everyone has. Pardon me. And so this topic is critically important, and I think we're going to see it in upcoming articles, and also we will cover it in webinars, and this is the mortality rate at time of delivery. Second, May 4th, there was an article that hit the New England Journal of Medicine regarding bystander efforts and one-year outcomes of out-of-hospital cardiac arrest. And as most of you know, over the last year, we've been working on our MedTac program on sudden cardiac arrest. This is the first article that has a very large series reviewed and addresses the long-term consequences when we don't have bystander CPR and AEDs, and actually has shown the evidence that bystander CPR and AEDs reduce admissions to nursing homes, long-term, all mortality, stroke, and neurologic consequences. As you all know, May 13th, we've had this cyber attack with the WannaCry ransomware, which has been in the news. pardon me, and over 150 countries, and we're tracking more and more. And variations of this are likely to strike. It targeted a number of UK hospitals that caused the delay of patient admissions, reduction in outpatient appointments and cancellations, and also scheduled surgeries. So I think we're going to see more of this in the cybercrime, cyber harm area, which has been a topic we've been covering over the last 2 years, especially as it relates to contamination of medical records, and because it is a patient safety issue in the patient safety wheelhouse. The identity fraud news for 2016 has gone up, and there have been more and more breaches. We know that the breaches have gone up in healthcare, so the medical and healthcare breaches have gone up to 377. It's over a third of all of the breaches, all industries. So we see this continuing to climb. The number of records that are contaminated or breached has gone down, and that's because the year before we had over 80 million just with one. So I'm going to shift gears now to just cover our polling questions before we address the topic of sepsis. But we ask you, are you interested in more detail regarding failure to rescue? And this was after Dr. Huddleston has helped us understand that failure to rescue, recognition of the deteriorating patient is a very, very important area of omission. And we had 59% of you give us a 10 on a Net Promoter Score, 99% agreement. And so we will be addressing this in future webinars because of the strong survey result. The topics that you gave us, and I won't read the slides, but there are topics. We always give you free text entry topics to provide to us that you want us to cover, and you can see early identification of sepsis is in this group as well. So just this is a backdrop to today's discussion. The interest in performance improvement topics, you're interested in topics for performance improvement. 73% of you gave that a 10. And so this reiterates not only the topic, but also performance improvement areas. And the areas for performance improvement that you want are listed on slide 18. Again, I won't read it. We asked the question, are you interested in triage performance improvement topics? A little lower score, 90% agreed, with 43% of you giving it a 10. So that's definitely a strong endorsement of your interest in us covering those topics, and the triage topics that you ask us to address are in slide 20. So I'll shift gears now to the MedTech program that we've been working with over the last year. MedTech, for those of you that are new to it, we discovered that the 7 leading causes of death and harm, but causes of death in children in schools, the colleges, and workforce are these 7 areas, with bullying including workforce violence, which is a precursor to violent intruder events that can occur. And this started with our work in active shooter events and expanded to cover sudden cardiac arrest, out-of-hospital sudden cardiac arrest, choking and drowning, opioid overdose, which is now just an incredible epidemic, anaphylaxis, major trauma, including active shooter events, and management of bleeding, common accidents that don't fit into the major trauma area, and non-traffic related transportation accidents. We developed a program on one end of the continuum for school children from 3rd grade and above, for Scouts, Cub Scouts, Boy Scouts, Girl Scouts, and then for colleges, and then on the other end of the continuum for physicians, nurse practitioners, and nurses for CEU programs. And the focus is on bystander care, pre-hospital work with the emergency medical system, and the definitive care that's seen and delivered in the emergency department. And so this program's been very successful. It piloted in California. After the first 7 weeks with just one class, the first life was saved. So we asked the question, would you like to have help in starting a MedTech program in your local community for schools? It's a 10-hour program. It includes the Stop the Bleed program that is endorsed and helped develop by the American College of Surgeons after the active shooter events. as well as the American Hospital Association and American Red Cross CPR programs and AED training. And so we got this kind of response from you from our surveys on that. We ask you what topics that you'd want us to address. That's on slide 24. And so that leads us to now our introduction to the topic today with Dr. Ryan Arnold. And Dr. Huddleston texted me late last night, and this morning she felt terrible that she could not introduce Dr. Arnold, but wanted me to let you know that we'll post-record a short introduction and have her re-review the mortality reviews and how this ended up to be a very, very important topic and recognition of the deteriorating patient dealing with sepsis, diagnosis, and opportunities for improvement. And so we'll slip that section in. However, I just wanted to let you know that the continued collaborative work that she has been developing and a collaborative that she is offering nationally includes a lot of focus on this area. So we're really pleased we'll be pleased to have her log on. We'll notify you when that is up with her slides so that you can get a more complete set of slides. However, suffice to say that this is a very important topic. This is an area that the Mayo Clinic focused on and has had significant impact, and that a number of the hospitals in her collaborative, now international, will be focused on that. So without further discussion, I'd like to introduce Dr. Ryan Arnold. He is a practicing physician, an emergency medicine physician, and research director for the Department of Emergency Medicine at Christiana Care Health System in Newark, Delaware. He also serves as a senior clinical investigator at the Value Institute within Christiana Care. I am so sorry for my still recovering from this flu. He has a master's degree in medical science from Boston University School of Medicine and his MD from Loma Linda University School of Medicine in Loma Linda, California. Following his residency in emergency medicine, he undertook a fellowship in shock research at Cooper University Hospital, focused on the design and execution of emergency medicine and critical care clinical trials. So for 10 years, he's been focused on the primary investigative efforts on crucial aspects of care of the sepsis patient, from the novel diagnostic biomarkers and risk stratification of sepsis to the clinical trials investigating the effectiveness of resuscitation protocols and novel therapeutic agents. He's participated both as a principal and co-investigator in multiple prospective clinical trials, both NIH-funded and industry-supported. So it's a real pleasure to invite you, Ryan, to take it from here.
Thank you, Charles, and I want to thank Jeanne and everyone for the opportunity to discuss this today, and really look forward to sharing some of our approaches and the shared challenges I think we all feel in addressing this population, and kind of start the conversation about the steps forward. So the title of my talk today is going to be Pragmatic Sepsis Care for Providers, and it's aligning evidence, guidelines, mandates, and policy to inform your daily practice. This is recognizing that we, as at the bedside provision of care, are tasked now with addressing disparities in recommendations and even definitions for this population, from the recently published JAMA article on the consensus for the new definition of sepsis, guidelines from the Surviving Sepsis campaign, in addition to the CMS criteria that they have defined and recommendations they have for care. And how does this affect you at your individual practice parameter, let's say it's at the Mayo Clinic or any other institution? How do you align all of these somewhat disparate concepts into the appropriate care of these patients? So our outline today, we're going to be focused on three main objectives here. I'm going to start by doing a little preaching to the choir. I'm going to talk to you guys about summarizing some of the challenges that we have in the sepsis definition malalignment that we've all felt. Then discuss the actual care for patients that we do on a regular basis, and provide maybe an operational approach that you could adopt or consider looking into that we have used for sepsis identification at our institution. And advocacy for making sepsis an actual emergency, and what I mean by that, we'll outline some of our own emergency department-based efforts across alerting and responses for this process. So let's start with some preaching to the choir. I think we take a 30,000-foot view of the sepsis spectrum and don't get lost in the weeds of definitional thresholds, we've took a step back and recognized that it exists on a spectrum, and the recognition is on that spectrum is that any infection, be it bacterial, viral, of any etiology, can progress into a systemic response that then starts to harm a patient and puts them into the sepsis continuum, and that is during this continuum then that this patient will develop conceptually increasing amounts of organ dysfunction where their severity increases, and this is pictorially represented here, and it can be in any order, but organ dysfunctions including kidney and renal dysfunction, GI dysfunction, the respiratory system dysfunction, and neurologic dysfunction, and then as it culminates into a profound refractory hypotensive response and a blood pressure drop that is not improving with therapy, they become into the septic shock criteria and as a concept. So now this conceptual approach allows us to say, that we agree that what it means, and then that's the challenge of making the next steps towards operation and putting it into practice. And just to give a little background for those that may not be aware, or just to remind us all, kind of how we've got to this convoluted place we are today. When the initial release by HCUP and AHRQ came out with data showing how expensive septicemia was, and by all accounts of those that are in this field that work in this epidemiological space would attest to, this is likely an underestimation by any large amount of percentage, but still showing it's still number one and most expensive. In that response, what happened was CMS came out with their recognition of its importance, and from that, their own definitions of who has this syndrome and what should be done about it. We've all have been aware of this, and I think it's part of the challenge that brings us to the discussion we're at today. This outlines the CMS criteria in short, and talks about the requirement for that infectious presence to have the definition of a systemic inflammatory response, but then is coupled with an organ system dysfunction, as you'll see. The details aren't too important right here. We're just going to talk about big picture here. And then progressing to a shock state, which is defined by a low blood pressure or elevated lactate. Now, CMS then went on to say, this slide represents kind of a summary of their recommendations for care, that in these patients meeting these criteria, you are then having a time-stamped based metric for performance to have certain things achieved in the care of these patients. So in the beginning, it could be antibiotic administration, blood cultures prior to the antibiotics, a lactate assessment on that patient, and then a repeat one if the first one was elevated. And then if that patient progresses to the shock criteria, then you will have to give a certain amount of fluid and administer vasopressors if necessary, with an assessment of that patient's response to those interventions by a perfusion assessment. That could be a physical exam, bedside echo, fluid challenge again, and some derivation of that. Now, this kind of led, this is what the current standings of recommendations are from the CMS, and they are currently only in the data gathering phase. However, the story of the confusion prompted a lot of investigators to say, and concerned, researchers in this field to say, well, I'm not sure that those criteria that you're using are adequate. And this is a very strong paper, came out in the New England Journal by Kakaunen and Bolomo's group out of Australia, showing that while, yes, it's important to know what SIRS criteria are, because the larger your inflammatory burden measured by SIRS, the inflammatory response syndrome, the higher outcomes of mortality you'll have. You'll notice that normal, or the lack of finding those two SIRS criteria that is mandated by CMS, does not confer a benefit of mortality. And in fact, the concern from many of those on the side of the inclusiveness of the definition was that you'd be omitting patients who would actually absolutely need and require therapy, but yet would be, because they didn't meet this arbitrary threshold, be excluded. So from that, again, then addressing the what do we do with these patients, many are familiar with the famous trials that have come out over 2014 and 2015, multinational and multi-hospital and centers and institutions, where they essentially tested all the regimented algorithms for the care of these patients compared to standard bedside, kind of just whatever the clinician decided to do, and found that there really was no mortality benefit conferred from any of these mandated recommended interventions versus a standard kind of bedside attentiveness. So what does that leave us? I mean, we still have these requirements, but what happened in the historical kind of story of this is that the consensus group came together and said, got a lot of the key opinion leaders and experts around the world within sepsis, and said, let's come to a better conclusion about who these patients are and how do we find them and what is our goal here without really putting forward a treatment plan per se, but really making sure that we all could agree upon who had this. And so they came up with this concept of the new definition of the Sepsis 3 as the new iteration, which defined, removing any specific requirements of inflammatory markers, but really acknowledging that you're now identifying patients with infection who have what they've dubbed as a dysregulated immune response or host response to their infection that results in that organ to system dysfunction, as we discussed. Now, they use their surrogate of a SOPA score of greater than 2 points, and then they define what shock is as this vasopressor requirement, also with an elevated lactate to be measured at that time as well. So this is the current standings of those new definitions as they stand. And you'll notice that in this representation, it puts them in our comparison visual here on a different line compared to CMS. And so what happens then is you are faced as a provider, bedside physician, nurse, or a policy driver at your hospital with the challenge of saying, okay, we have to align these two, and do I have to pick my line? Do I pick where we go? And where do we as a system define those thresholds? And so you'll notice in this visual that we put together, just kind of representing the challenges, if you will, and not necessarily an answer, but you'll notice that in pink you have the Sepsis 3 definitions for organ dysfunction thresholds that they've used, and then in the blue you'll see where CMS is defined. And the ones in lighter, pink that you'll notice are kind of other clinically assessed and kind of agreed upon, organ system dysfunctional measures that aren't necessarily represented in these values. So the challenge there is that you recognize that, well, clinically at the bedside, I'm worried about this patient, but they don't meet the CMS definition. So now what do I do? Do I name them? Do I go down a CMS treatment pathway? Even though, and a lot of those challenges have been plaguing a lot of our response staff and our administrative staff in policy derivation because of this agreement. And I think it's important right now to just take a quick comment on how we got there and why, because there are competing objectives that even drove the presence of these. And when you have nurses and physicians at the bedside taking care of a patient in front of them, they're then confronted with these guidelines that are maybe disparate to their current assessment of the patient in their care. And what's important to know is where these guidelines are targeting. These guidelines are targeting populations, and they're looking for recommendations that kind of guide the overall care of a population of patients based on population-based numbers, aggregates. Whereas we at the bedside are saying, I need to take care of Mrs. Smith in front of me right now, and I need to now somehow take your population-based recommendations and apply it to Mrs. Smith and see if it fits her. And you'll hear many of the experts that have come up even with these policy recommendations and guidelines that say these are not rules, these are to guide the thought process, but you need to take into context your own acumen at the bedside. And that's very important, but it still represents a challenge when you have thresholds that are concretely defined and a system that's trying to come up with a solution there. And the question becomes then is, where do you all stand? Where do we all stand? And you could put any institution here and put in there, and this theoretical line that I've drawn here just represents a decision point that has to be made when a system, wants to define their population, and going with, their objectives on being inclusive, to be aligned with certain criteria or not. And that's the crux of the challenge here. So we can then move on to saying, okay, let's take care of actual patients with sepsis, and how are we going to approach this to address these issues. I want to highlight how we've done this and put in a context where I think is one where many of my providers can understand this, is that I think there's a lot of the rationale here behind why sepsis can be the perfect patient safety initiative. And I think that it is challenging as opposed to other disease entities that we care for that have very many efforts surrounding them for time-sensitive responses. And so everyone's familiar with, responses for the acute MI and for stroke and trauma and sepsis as well. And that with all these scenarios, the illness severity on a y-axis here representing the increased amount of severity and requirement of response, many are familiar with the time windows, within these disease entities. So there is the golden hour of trauma, the 90-minute door balloon time for acute MI, the 3 or 4.5 hour thrombolytic window for a stroke, depending on your school of thought, and all those things are time sensitive and initiated and brought a lot of resources to bear to meet those goals. And sepsis will fall into sometimes when a patient arrives in their highest extremis of disease and gets early aggressive care.
Hey, Ryan, Chuck here.
Yeah.
Your audio is going in and out a little bit if you're not close to your microphone.
Oh, sorry. Is that better? Is that better?
Yeah, if you can get the microphone close to your mouth, just want to make sure that everybody can hear you. You're a terrific
Absolutely.
talk, and I don't want to miss anything.
Absolutely. Is that better now?
Yes, sir.
Okay, great. So then when you extend on and looking at these patients, extend on beyond the initial response for the obviously ill and high resource requiring patient, the disease severity, as it would be expected in other disease entities, will be improving. So what I mean by that, and this is a very oversimplification, admittedly, but it serves the point of looking that we expect our acute MI patient who recovers from their initial intervention and care to somewhat improve and not have a repeat MI while they're in hospital. We expect our trauma patient not to have recurrent trauma, but to hopefully respond and recuperate. It might take some time, but they will be improving over time. Similarly, our stroke patient is likely a fixed illness, fixed disease that is going to take months for recovery, but nothing will be continuing to evolve and worsen. Again, oversimplify, but really within sepsis, the disease itself is one that really is indolent and is showing many of its signs of that progressive dysfunction, deterioration that results in those rapid response team needs and deterioration events that can happen days after their initial presentation. And that is not unique to certain types. Many types of infections will have this progression, and it can be very indolent, requiring a high level of clinical worry and grit to focus on these patients over a long haul. You can imagine the different steps and handoff and process of care issues that happen over several days, where you can get a lot of people to focus a lot of energy for a short period of time, but then require that level of rigor to happen over days when events can happen on 5 and 6 days later is a challenge for a system. So an approach that we've come up with, and this has been in a collaboration with a National Science Foundation grant that I'm working in collaboration with Jeanne Huddleston at Mayo, as well as a collaborator and the PI, Christiana Care, and driven by NC State with our analytic hub, looking at how we've approached this problem by saying that we wanted to optimize it with a big data kind of effort to employ data mining and machine learning to really understand the disease spectrum of sepsis and correspond more personalized therapeutic interventions in the future. But why this might be portend to or help us in our active patient care today is that we were challenged with having a large data set with 30 months of consecutive visits and 146,000 unique patients with 244,000 unique visits, that we had to find a way to find these patients, and we knew that we were limited by diagnostic criteria, would be missing many of the patients that met our criteria that we were worried about. And so the objective we had to come up with was to find an EHR-based approach that allowed us for real-time identification of these patients, but it did not require direct chart review. We couldn't go into 30,000 charts, right, and verify this patient was truly meeting a specific criteria and what that was going to be. We also didn't want to wait until ICD-10 diagnostic time, because that often is also, we know, omitting many patients that meet the criteria where the clinical team might have dubbed them pneumonia with acute kidney injury and dehydration with hypotension, where in fact they met sepsis criteria and just weren't labeled as such. So from this, we came up with a concept that we think is now beneficial for our operational response, and that is to start with the foundation of increasing that denominator, if you will, looking back to the paradigm figure that we kind of outlined, and that we want to know our entire sepsis, our entire infection population to start, because that's the group that is going to advance and deteriorate on to the sepsis actual disease state, but they will start with an infection. So we define the surrogate being the clinician kind of assessment of that patient, initiation of antibiotics or antifungals, or antivirals. Anything that's anti-infective is taking that physician to assimilate and say, okay, this patient needs anti-infectives for an active infection. So we would use that as our surrogate, recognizing from the beginning that we would have a much broader-based definition for anyone of target because of the lower severity, but at least we wouldn't be missing patients in this early phase. We also looked at specific measures like PCR testing and virals that we know have a high specificity like influenza that are unique and not going to be having false positive rates that are very, very high. We then looked at the inflammatory burden, recognizing that it's important to assess, as you've seen from the previous data, that increasing burden of inflammation was associated with increasing mortality. But the uniqueness of how we approach this is we didn't require any inflammatory criteria to be present in order to define the sepsis state. And that is aligned with that Sepsis 3 definition. It's recognizing that patients have different immune statuses, and then also hospital responses and care patterns might have different assessment times that may miss one of those key diagnostic criteria where a patient spikes a fever but doesn't have it measured, and so therefore it never really happened. So knowing that case it happens routinely, and we'd rather just be able to capture the data when we see it, but not require it to be present to then define the sepsis state. And then we faced the organ dysfunction, recognizing that was the key component that transitions the patient from that infection spectrum into sepsis, and that this organ dysfunction, though, could be any of those organ systems that were dysfunctional. Again, recognizing that we were broadening this a bit from the current definition, from the consensus definitions, because we were including even a small amount of organ dysfunction and not requiring for example, as they had stated, a SOFA score greater than or equal to 2, whereas any amount of dysfunction we would deem as important and would put that patient somewhere on that spectrum. We classified these dysfunctions by families, but really gave them very hard, concrete metrics for assessment, allowing us to then define the burden of organ system dysfunction and how that relates to outcome as well as illness severity. And the specifics behind these definitions are more than we need to get into in each individual one, but to highlight a few of them that have helped us to challenge what we have previously done and been lacking is recognition of the respiratory component, how challenging that can be, and the lack of data, for example, of many patients that don't have, as advocated by the current scoring systems, arterial blood gases that allow them to define a patient requiring oxygen support, that we know that there's other ways to measure that. And likewise, measurements of kidney function through not just isolated creatinine values, but BUN has been validated by previous studies, or also urine output. So a much more broad swath of organ dysfunction, allowing us to capture more patients. Again, at various disease stages. And then our shock stage, and this is one where we had to be a little more creative because we recognized that while the definitions were very focused on a very high severity population with a high mortality rate, with the objective of saying in a population-based approach, you will have a very high rate of mortality when this group, for example, the Sepsis 3 definition requiring the lactate be elevated in addition to vasopressor therapy. Well, operationally, we know that vasopressors independent of lactate are going to change how we care for that patient. They're going to be in an ICU level of care as opposed to a lower severity. So we also recognize that we didn't want to require clinician response and the team delivery of care to define a state of that patient. So our example here that is important is that if a patient gets missed, for example, with hypotension, and that hypotension doesn't get fluids for 4 hours, that patient, by definition, on the other criteria, would not even meet shock criteria until they receive some fluid therapy as a challenge. Well, that obviously doesn't really fit with how we would look at patients in these outcomes, right? We would say that patient has been in shock for 4 hours, just was unrecognized shock. And so that allowed us to capture these patients, call that an event as it was, and as well capture that any vasopressors at any point was now a shock state as well. So with this paradigm, we can now go through and chart a patient's progress and where they were, how they're moving through the system, and not draw a line in the sand and say, no, you are not anyone of interest until you reach this point, because that doesn't allow us to maybe make some improvements on earlier recognition of that point. So in this paradigm, you can imagine very different scenarios that would define patients and allowing the system to be more aware of the burden behind the treatment of the entire infection spectrum, of which sepsis is part of that. So a couple of cases we can go through just as examples of what this would look like, but you can imagine that how these pictures will tell the story of your patient and when things occur, and why that challenge is by the definitions that are currently there of timing and timing of presentation and timing of disease deterioration are somewhat arbitrary and not necessarily fair when we're trying to provide the best care for these patients. So in this case, you have a patient who comes in with markers of infection from the beginning, but doesn't develop their organ system dysfunction until well into their first day, so a day and a half in. And then they progress quickly to septic shock and they develop organ system dysfunction. Now, this one you'll notice in an example where this patient doesn't recover from their organ system dysfunction. They go home with some chronic disease that they didn't come in with. So maybe it's acute kidney injury that becomes chronic kidney failure, chronic kidney disease. And that's something that you will see in this population to a degree. But that is challenging when you have to then go back to these patients and try to figure out acuity and presentation time. So we feel that this approach allows us to better visualize these patients and to see this in a way where the mandated thresholds don't exclude someone that we are caring about. Another patient here comes in with organ failure, progressive, and doesn't get shock again until hour 24, but does come back and resolve. And you can see by their, by the pictorial representation here, they have a resolution and complete recovery. And again, this is a patient that I think many people expect is the classic, if you will. They arrived at the door with severe organ system dysfunction and shock state, but then get aggressive therapy, recover, and improve. Now, granted, this is just for examples here. We know that this is rarely going to happen in 4 days, but just to plant the case here. And then the scenario, again, here's one patient who's kind of recovered, never developed shock, and that's evident by the lack of any shock state there. So going through this, the challenge this represents that we have to, as a system, come up with solutions to is that you can imagine in this one case scenario, we'll go through a specific patient. I'll show you the challenge that it comes to when you have to figure out where you draw your line to define your groups. So this patient is a lactate of 5 on arrival, develops low blood pressure on their first day, 24 hours in. That's prolonged. Then spikes their first fever on the day and a half in, and vasopressors gets initiated later on to their shock state. A lactate gets measured as elevated, and they finally receive a fluid bolus. Now, this is a theoretical case, obviously, but it serves the point to show you that when these patients actually meet the definition for the different criteria is going to be varied. And this same patient doesn't meet the CMS definition for sepsis until a day and a half in. Even though on arrival, we were treating them with infection, foreign infection, and identified organ dysfunction within hours of arrival. The sepsis 3 definition will actually give that patient the appropriate diagnosis when clinically.
Ryan, you're going in and out again. Maybe if your mic isn't close.
Oh, sorry. Is that better?
Yeah.
Okay. And then you'll notice here that the septic shock definition was CMS, even though vasopressors have been initiated, the therapy bolus of the appropriate amount was delivered. And in addition, then you can see here that the sepsis 3 definition wouldn't be met again until 2 days. The challenge here is that it seems almost.
Ryan, we're still having problems with your. You're just getting garbled about every other word. So
I'm sorry. I wonder if it was my signal.
Okay.
Let me try to move location. Is that better?
Sounds better now.
Okay. So the challenge here is that because there's so many requirements for care or diagnostic tests to be done to meet criteria, you see the inherent problem in the system where the patient wouldn't get labeled appropriately because of some arbitrary definition that we clinically know is not impactful to our care that day. And so that has allowed us to say and recognize the challenge. And that challenge is one that you have to kind of acknowledge from the beginning, and it's the inevitable law of unintended consequences, that when you draw your line and you set your goal, you will have set up a population that you are going to omit. And this is exemplified here by the shaded group, which is the omitted population. When your goal was in CMS compliance, which many places is their only current goal for sepsis care, and that's a good place to start. I mean, start someplace, but recognize that you are omitting a population in whom will likely meet criteria for your disease entity of interest. For example, in the scenario, you can see many patients omitted with that definition because our only goal was to meet when CMS was defining that patient. And it also tells our clinical staff maybe an inappropriate message, which is don't label that patient sepsis because then we have the CMS measures to contend with until they've met this, let's say SIRS criteria, where in fact the team has already acknowledged that this patient is well into their sepsis syndrome. And likewise, if your goal is the evidence-based compliance with sepsis 3, you're going to have a different, unique set of omitted patients that are no longer meeting your definition. And so the challenge then is becoming what a system will draw their line in the sand and what they do for who their patients are defined by. And that leads us to kind of the next, kind of big advocacy on making that step and actually, coming down with a defined group and definition that your system will come with, and how we make sepsis an actual emergency. And I'm going to highlight how we've done this within our ED and our hospital efforts for not only identification but response. Now, this has taken the form of like centralizing the focus on sepsis and addressing the different populations of interest that we feel are going to be key in making headway in the care for these patients. And that the care means the early identification as well as rapid responsive therapies. And so the focus is not only on our providers, and that's simultaneous and synonymous education for both nurses and physicians, but our patients and the families, and recognizing the value of them being equally aware of these efforts. And then as well, the hospital administration, those that are, tracking the systemic burden of these patients on the hospital. And so when we look at this in the context of layering the awareness of what we hope that these key messages hit these providers on these different levels, is that the awareness from the provider's perspective drives a common understanding of disease severity. So there's agreed upon vernacular, if you will, of everyone understanding that this patient has X number of organ systems dysfunctional to this degree, and we all agree upon what that label is going to be. Whereas your hope for the administration is that they are now better appreciating the true system burden by being more comprehensive in an approach like we've outlined today, not just focusing until a patient meets these very finite definitions, but much more broadly about the burden of the infection spectrum as we care for it as clinical teams. And then the disease label for the family is important because of their own advocacy they can provide. And what happens is this awareness, we hope, then layers and drives a response that is unique from each group. And that the response on the clinical provider side is an improved clinical vigilance, where there's an agreed upon and a shared model of how we address these populations together, as well as then from the hospital administration side, resource support provided to enable these initiatives to be successful and to be measured and to be watched. And then again, the key that I think is so important in this is families and awareness, both the patient themselves and their family, because of the advocacy they provide. And the example that I often give in this is the understanding of interpretation of data, which oftentimes feels very concrete, and yet its value can change drastically depending on input from a family member. So a patient who has a chronic lung disease, when a family member will tell me, this is not how my mother breathes. She normally is at this saturation or this oxygen requirement, and they're now able to tell me that in the last 12 hours this has dramatically changed. That would have me interpret very differently a current presentation of vital signs and abnormal lab values than someone who says, no, she's always breathing this way. Her lung disease is horrible, but it's no different today than it was last month. And that is only possible through that kind of interactive phase. And in addition, the families being aware become their own advocate to watch and monitor their patient. And as challenging as I know that has been as a provider, it is such a necessary component, especially for a disease that has such a long tail of deterioration events that can happen days after their arrival. So what we've done at our hospital system is come up with our version of making sepsis awareness both system-wide as well as the true medical emergency that it is. To give a context of what we do, typically we have a system in place in which alerts are not like, as you would imagine, a monitor alert per se. This is actually an alert that drives a clinical response. And up until recently, they have been in place for trauma, stroke, and acute MI or heart attack. So we had an alert that goes on because announced overhead to the entire hospital system. It garners the support for the needed regimens of providers that will take care of that patient. So a trauma alert brings our trauma surgeons with our emergency team to care for those patients. A neuro alert will then get our stroke alert, gets our neuro team to respond, as well as a heart alert will get our cardiologists and interventional cardiologists to respond. So now we've elevated sepsis to this alert status, giving it an ability to be recognized. And so what this looks like is the following. I'll go through both the criteria that we use in alerting and then kind of the response that it drives. And this represents, essentially, you will see the line that we have drawn by defining how we define this criteria for these groups. So this now thinking of the sepsis alert response is the criteria of any kind of antibiotic, antiviral therapy that's ordered by our physicians, and then any presence of any one of these organ system dysfunctions. We recognized from the beginning when we came up with this iteration that we were now going to have a much broader population of those who meet the criteria that require this alert. And the challenge with that was recognizing that, well, while we know that is going to happen, this is how we often work with many of our disease processes that we respond to, and that is that we maybe over-quote triage or make sure we're not missing patients because we know that if we have missed scenarios, the outcomes can be rather dire. So any one of these organ system dysfunctions here allows and empowers our team to say, okay, you've met the criteria, we need to move on to a system-wide response that is, elevating the awareness for this criteria. What happens then now, our clerk calls it over into our ED team. This one stays within the ED only. This does not go hospital-wide, this alert. And it drives a discussion that happens that we try to have have a bedside kind of, huddling that occurs as you would with a trauma or a heart attack, where the team is discussing the interventions that they're driving, the therapeutic discussions on if this first goal of care is at the appropriate level for this patient. Do we have appropriate IV access? What fluid bolus are we giving? Are we giving any fluid? How much fluids? What's our antibiotic plan? And what diagnostic tests are still lacking or do we need or is going to be necessary to move forward? And you'll see on the right is like our team is defined, our physicians at the top, our emergency department residents if present, our nurses caring for that patient, our ED pharmacists that if they're available as well will be at bedside, and our research team that helps us with some of the data gathering. So this response has now elevated everyone now is aware in the ED that this is going on, and much more kind of upping the kind of system-wide overall response rate. Now, then you can progress on to what we call our sepsis code. So our system has an alert status and a code status where you will now up your level of response and reporting. This is only achieved after the initial resuscitation and efforts on that sepsis patient. And then what happens is if there's persistent hypotension or persistent lactate elevation, we recognize that these patients are going to require possible vasopressors or definitely an ICU assessment as they have a high rate of deterioration and requirements of a lot of interventions and monitoring. So this then goes overhead. This prompts an ICU response with our ED team to rehuddle now and discuss where this patient is on their fluid status, what the next level of fluid therapy is going to be, what's the plan for central access. It doesn't drive any of these one things in particular. It just drives the discussion. What do we need to be doing here? Let's make sure we're on the same page. As well as reviewing anti-infective spectrum, what is our goal here to make sure that we need to broaden our spectrum, and then on the diagnostic side, looking at repeat lactates, and that helps us be compliant with the CMS, but also still being in the standard that we think is clinically relevant. We also threw in here some recommendations, as you guys might have run through with previous mortality reviews and sentinel events, is source control issues, and the recognition that now you've reached a state of higher severity shock scenarios, and now do we need to consider more further imaging, MRI of spine for epidural abscess, LPs and look at CSF for encephalitis and meningitis. Not mandating any one of these tests, but just a consideration and saying, do we have appropriate source identification and control? If not, do we need to do further testing? So this process, as you guys have all been aware, and I think and what Jeanne Huddleston has really driven such an amazing, kind of valuing the need for the feedback loop that is so inherent to the success of any initiative that changes practice. And we likewise are looking to provide both immediate feedback for these patients in addition to delayed feedback. And the delayed, I'll explain to you why it's delayed, but you can imagine if these sepsis patients don't experience their outcome until days later, it's very hard to know when that occurs to then get back to the team that took care of them. So we've come up with a way to try to do that. So I'll show you what it looks like in our initial drive is a feedback loop that is more immediate and provided to the treatment team, but it's to provide to every member of the treatment team, highlighting for them, where their patient was to remind them who the team members were, and what initiatives, kind of were addressed and maybe could be improved upon. And you'll notice that we are, again, not mandating an actual item of performance like a antibiotic by a certain time window or an amount of fluid. Right now, we are focused completely on just the discussion if it has happened and, the iteration of the appropriate labeling. You'll notice that we have a CMS box there of compliance that is helping us, to have an awareness, but we're not driving any actions right now until we've decided that, that these initiatives have taken root and are successful. Because while it's important to know those, we really think that the initial awareness, labeling, and discussions that happen with the entire treatment team are going to be the most important for the outcomes for these patients. And then the delayed longer-term outcomes. So recognizing when these patients' disposition from the hospital, when they leave, will happen, days, if not weeks after their initial stay. So what we've done is we've kind of created a fun, way of approaching this and kind of acknowledging what happens when all clinicians and nurses take care of patients, is that we all are forecasting these patients on a daily basis. You look at your patient, you are essentially forecasting where you think your patient is going to go and be able to take their next level of care. Can they go home safely and take oral antibiotics, or do they need to be admitted to the hospital but not require ICU, or are they very, very ill requiring ICU level care? And that happens on a routine basis. And so we've dubbed this the forecasting the unexpected transfer to upgraded resources in sepsis, kind of trying to capture that gestalt of the providing team in a way that we can then go back and give them feedback to how their patient did and how their forecast was, but also give them real feedback of that actual patient. And the way that we do this is through this quality improvement effort that increases the awareness as our objective and really provides direct feedback to the clinical team as to the outcomes of the individual patients that they're caring for. The method we do this is through a gamification of the awareness process, so making it a little bit more fun by collecting their forecasting at the time of treatment and then giving them back how they are performing as a group by location and by specialty, if you will, like nurses, physicians, residents, and comparing them to each other in a little fun, fun way. This is made possible because we have a very robust group of resuscitation science internship of pre-med volunteer students that help us with data collection in these initiatives. And then we also pair with our value institute helps the analytics side to then score these forecasting and give feedback back to our teams. The reports are given to all the providers of the care, and as well as the administrators to watch and be aware of this as well. The forecasting assessment looks like the following. You'll see that it's all measurable, concrete outcomes. So there's no ambiguity in their occurrence, and that makes it very easy to then assign a score and kind of a performance, if you will. But it pushes our clinicians and our nurses to say, like, hey, how worried are you about this patient, and how does that translate to what you think is going to happen? How long will they be in the hospital, 3 days or 30 days? Are they going to have an RT, a rapid response team, occur? Will they have an unanticipated transfer to a higher level of care? So will they go from the floor to a step down or floor to ICU or step down to ICU, something that was unanticipated, where we thought they were some level of stability and then they were not? Will they transfer to an ICU in general, just capture a code blue, which is a cardiac arrest? Do they actually think this patient is going to die? And there's many that have really high concerns and that will say, yeah, this one I'm really worried about, and then actually make them put a number to their chance of in-hospital mortality. This allows us to give them feedback, and I'll say what the feedback can look like in this example here. So this is an email to one of our providers that we've, obviously taken all of the identifiers out of both the patient and the provider here. But you'll notice that they're provided their prediction and then what actually happened. And then on the bottom below that, you'll see in a little box the two locations we have. CED is our larger tertiary care campus in Newark, Delaware, and Wilmington is our smaller hospital center that we have shared providers at both sites. And you'll see that their performance is put up there and how their scores are, and it's a fun little comparison. It's somewhat arbitrary, we understand, but it allows for that somewhat kind of increasing the awareness and the participation of all of our providers, in addition to giving them actual feedback on how their patient did, and they can recall that patient and look them up if they wanted through identification numbers to go back and get some feedback. And then the third arm that I mentioned was the patient and family advocacy, and we've partnered and have been working with the Sepsis Alliance a nonprofit group that really has an incredible, really very focused mission on helping to raise the awareness of sepsis to the medical emergency that we all believe it is, and by providing great kind of patient-level information that we are now incorporating in our care models and trying to build this support level, and through these inspirational movies that kind of tell real life patient stories and survivors or patients or family members of survivors, as well as these patient information handouts that we can provide our patients and families, that how sepsis can actually be the label that they didn't know existed, but yet is applying to their influenza. It could be applied to their post-surgical or their pneumonia kind of scenario, and why that's different in certain populations, but what it affects. It also is addressed for the first time, something that has been advocated now by CDC, who's paired with Sepsis Alliance, to look at what is life like after you have a very severe illness like sepsis, and how do you recover from it? What should you expect, and what would be the next steps forward? These are vital understandings that really empower the patient and the family to feel more like the severity of their experience is being appreciated by the team. And I think it's helps them understand that when they will ask us questions like, oh, it's not just pneumonia, they know it's pneumonia with sepsis. It really pushes them to really be more vigilant and advocate for their family member. So, kind of to wrap this up and to kind of open for discussion and question, do have some concrete kind of like next steps that I think are important for any institution as we address this population. Is to come across, the first one is just to define sepsis as your system well. I think it's important not necessarily to follow exactly what we've purported here, but something that your institution agrees upon, and it should be location independent. It shouldn't matter where you are. If you're going to meet a criteria, it should be met independent of ICU, ER, medical or surgical floor. And then, this is, our model of the sepsis IOS, we affectionately call it the infection, organ dysfunction, and shock spectrum, is one thing that we think is a little more inclusive and allows more flexibility for the clinician to say, yeah, you want sepsis, but you're low severity sepsis because you only have a single organ system that's mildly dysfunctional. We think you're going to improve. We feel it empowers our team to feel more able to accurately capture the true burden of this syndrome and this disease in their system. And then transparent labeling of sepsis. So once you've labeled it, that everyone's aware and on the same page, from the nurses and the bedside physicians to the patient and the families themselves, as well as the administrators, to better track the true incidence and the burden on the system. And finally, to make sepsis an emergency, I think it's important to establish expected response protocols. And what do we hope to kind of endure and to have happen once these labels are attached, and next steps, because I think that's in our experience, the interesting thing that I've noticed from patients and families is that they may be told an entire care plan for a disease entity, but once that label gets appropriately added, they say, well, now what? And there should be an answer to that question. What are we doing differently because as you've asked that criteria for this disease process that we know is a huge burden and danger for your loved one. So with that, I think we can maybe open up for questions or comments, or just other suggestions or experiences you all have had, and welcome any input.
Great. Well, thank you. Thanks for such a comprehensive overview. What I'd like to do is draw everybody's attention to our poll. I think, Brian, what we'll do is do a quick poll of a few questions, and then we're going to ask everybody to submit their questions in the Q&A section in the lower right-hand corner of the screen. But we'll just cover these very quickly. At the beginning, when we talked about the news, this whole cyber security issue, the breaches and contamination, we wanted to ask this audience, do you want more detail on cyber harm and patient safety? And give that a scale of 1 to 10, strongly, very strongly agree, and 1 very strongly disagree. And then please put your free text entry questions that you'd like to have answered or topics that you'd like to have covered. The second is you're interested in more detail regarding sepsis. This is part 1 of a 3-part program. We're dealing with it as an emergency in ICU and a number of other topics. And so we just want to confirm that you want more detail on this topic. And then it will help Ryan and I and others as we're planning going forward the next two months. what specific topics, now that you've had your appetite whetted a little bit with this presentation, what topics would you like us to address, questions or challenges that you face? Please put that in the free text entry. And then the next question is, I'm interested in medical record recovery post-cyber harm. And this is regarding a topic about 6 months ago, we addressed this issue of medical record recovery, this issue of once medical records are contaminated for any reason, and now we've got frequent contamination due to cyber harm and fraudsters getting a hold of medical records and contaminating them. And then what kind of recovery topics would you like to address? Ryan, only 19% of healthcare institutions have any program of any type to help them restore medical records after this has happened. So those are the topics that we'd like to address. And what I'd like you to do is also enter the questions that you would like to have Dr. Arnold answer, and that would be terrific. I guess the first question that I have is for organizations that are really interested in getting a program going and really getting much more active in what they're doing. Ryan, what would you tell those who recognize that they've really got a challenge here and have to get started? What would you recommend to them?
I would say that, like, initially, just finding some champions at different levels of care. And the biggest thing I've found is then where you will find a group that can help you get awareness and get the response to be generated. So the initial step, I think, is always finding the champions on different levels, from nursing as well as physician perspectives, and kind of initiate and say, let's find out how often this is actually happening in our institution. I think that's the first step that we did. That really, we knew there was a problem, we just hadn't quantified it yet. And once we quantified the number, we got a lot of attention. And I think that was where things started to move and resources started to open once we showed them how, in fact, big this population was.
So would you recommend getting an operations administrative champion? At Mayo Clinic, they've got the clinical leaders are coupled with an administrative leader, and they work together kind of side by side. Many organizations, you've got the clinicians working in one kind of hierarchy, and you've got your suits and your professional administrators working in another. What would be the best set of champions an organization might want to get involved in this in order to get the resources you need and the focus you need?
Yeah, I think one thing you mentioned right there is a huge, I think very commonly, which is clinicians only working with other clinicians and not speaking to the administrative side of the system, and partnering with those who have expertise both in the data acquisition, just who can get into your EHR and get you the numbers you're looking for incidents. Pairing that with outcome with your SIM would be important. If you can get someone on from the administrative side of teams who can talk to start looking at how to take that data from your acquisition side and put it into a viewable output, if you will, if you're unable to do that. But I think that partnering with those that are not in your exact practice parameter is one of the highest successes I've noticed. I think that one thing that Jeanne has been pushing for the longest time was this collaboration also with the engineering side, with the engineers' approach and how they approach these problems and defining the group. And it's really changed how I think we've been more comprehensive and able to get some movement here and there. So I think that you can't do this alone, and you cannot do this with just surrounding yourself with people that are like-minded. I think that you have to, meaning just your nurses surrounded by nurses or doctors surrounded by doctors. You need to have everyone a multidisciplinary approach to support, and recognizing that the person that can get you the data from your analytics side, it has a different skill set than the person who's providing the care at the bedside, but they are very much complementary in this.
Great. And again, where your words are coming in and out a little bit, so if you can watch whatever you're doing to improve it, it works great. Cynthia Ritter asks, when MICU response to sepsis alert, who does that include?
So that's our medical ICU, and that in our system will be either a ICU resident or a ICU PA, in addition to an ICU nurse. So the two of them respond. There then, if our attending level intensivist is present, they will be there in person, or they will log in remotely through a telehealth kind of connection. So we have, essentially our providers from upstairs do come down at that point for the bedside assessment and can kind of like collect a plan for the next steps.
Great. And Bruce Bainbridge asks, do you have any suggestions for data programs that provide real-time notification of sepsis triggers?
Yeah, so that's a great question. I mean, we've all been struggling and trying to find that. I think that there are many EHRs, like I know Cerner and Epic both, as the two of the big hitters, have their own sepsis alerting kind of real-time trigger, and I think that those are a great place to start. My caution there is, and the only thing I would just have everyone be aware is, lift the hood up, so to speak, on those triggers and make sure you understand what thresholds turn them on, because some of them are lacking maybe
the criteria. We lost you in that last sentence. We lost you in the last sentence.
Sorry.
Yeah.
So I was advocating that, like, if you employ one of these trigger tools, whatever they are, so personally, what I would suggest, I haven't seen, I think if you have a Cerner-based system, you often have a limit to what they have at Cerner or what Epic has. So you might not have as many opportunities, but understand what the trigger thresholds are that turn that trigger on, because it might be lacking some of the criteria that you think it should include, and you don't want to assume that, the patient, and the rationale we always say is that just because it didn't go off, don't assume your patient didn't meet criteria. It could be a helpful thing when it does go off, but don't overestimate that that everyone's safe who wouldn't get an alert. So I think if people can create their own tool, that's even better. But in general, knowing the strengths and weaknesses of each tool is imperative. I think a lot of times we're all limited by what our EHRs can do, but if you could derive your own and have it align with your current kind of institutional definitions, that'd be the ideal.
Great. And Margaret Donowitz is asking, what is the bed size of your facility? Give us a feel for the scope of the volumes that you all are dealing with, and kind of scope and size, and maybe any thoughts that could help her there.
Sure. So our ER volume is at our Newark campus, we see about 130,000 patients a year, and then our Wilmington campus, we're about 70,000 a year. The hospital itself has an inpatient volume of about 1,100 beds. In terms of incidence of sepsis that we've looked at, what's interesting, and I know you weren't asking this per se, but our numbers, when we look back on what was actually diagnosed by the ICD-9 criteria from what we found with our new criteria, was that we had probably have about a 35 or 40% rate of patients that were treated for infection somewhere on the spectrum. So it was astronomically higher than we expected, and I think that was very important for us to understand how much more impact this was in the system and needed for improvement. So
great. And Jessica Leskowski asks, with all of the alerts implemented in your hospital, how do you combat the alert fatigue?
That's a great question, and I got to tell Jessica, that that's alert fatigue is something that we are very aware of, and it's funny because the term is almost one that I wish we didn't use, but it's so much the vernacular of our system that we use alert on these systems. But the difference with this is that you're right. We get inundated with pulse oximetry alarms that are false and blood pressure alarms that maybe were mismeasured. But what happens in this scenario is because every alert drives a response and every alert drives an action at the bedside, that has strengthened the response, because that when an alert happens, you have to then come to a response. And it takes away a lot of the alarm fatigue is when we learn that alert goes off and I go to the bedside, but I didn't need to, or I go to the bedside and it was a waste of my time. And you start to stop listening to them, and that's different than alarms that are going off inappropriately. So because we are very focused and objectively defining who we're going after, the teams are feeling empowered to respond to these alerts. Now, these are separate alerts from the other ones that are EHR based or like a computer system based. These are driven by a clinical team that turns them on and says, okay, we're launching a sepsis alert on this patient. That's very different, I think. So that's one way we're trying to combat it is to have them be very, very specific that when they go off, that the teams feel empowered for the appropriateness of their resource being dragged from wherever they were doing to this patient, that it was not a waste.
Great. And then Margaret Donowitz is asking, what are the goals? What were the goals did you initially set for improvement? So what goals for improvement did you initially set?
So our initial goals, we thought and debated this very carefully, and we're considering more stringent goals in terms of the stuff I mentioned that we did not do. So like an antibiotic administration at a certain time, or a fluid administration amount, or something to that degree. And we figured, and our initial goals only became the appropriate labeling and the bedside discussion by the treatment team. And that was a conscious, and deliberate step back, if you will, from more granular goals of like the metrics of performance, because we were hoping for teams to feel more empowered for recognizing and labeling these patients appropriately, and not feeling that this burden was one that was just too much to bear. And so rather than kill this before it started, we would hope that our initial goals were literally just the process of the care and the appropriate labeling of the patient. So did you label that patient sepsis when they met the criteria, even though you thought they were just pneumonia? And that's something that we're still struggling with. We're still working on. Our clinicians are improving dramatically, but it is a slower progress of uptake, because it's changing the mindset of how we've labeled patients, for years now, and really, reminding everybody that your patient needs appropriate labeling. And we think that is the initial goal has made it much more palatable for our teams, and not as not too much at once, I guess, in the beginning. So.
Great. And I have a couple more quick questions here, and I think we'll finish early, Ryan, so that the 10-minute introduction piece that we'll have Jeanne do after she watches your session, that way she'll also be able to really do a good job on the mortality reviews as they relate to sepsis and tie into your topics. So we will finish a little bit early today, and we do have requests regarding your slides, and those are posted at safetyleaders.com or safetyleaders.org. Kyle Kemp is our chief there leading that, and with all these recent things going on with the internet, we've had to make some adjustments, but they'll be available to you. And once Jeanne is home after she's taken care of her mom, we'll record her 10-minute session, couple that up with this so that it will be part of the kind of a combined session. The question that I have for you is you look at the different stakeholders in the game, what are the skills, what are the competencies that your work has taught you are important for your physicians to learn new skills, for your bedside caregivers, your nurses and staff to learn, and your IT folks to learn? What things should we really be focused on as we are continuing to enhance our learning and continuing education?
That's a great, I think, just topic that we've been struggling with, because I think that when we've seen successful initiatives and then things that weren't successful, one thing that part of this I take just directly from experiences I've seen with Mayo teams that I've worked with through Jeanne. But when efforts are addressed in a kind of bringing everyone together at the table to address them at the same time, and not passing the project off, if you will, to each individual expert to do their thing, but actually come and have this collective discussion. I feel that there's it's impossible to get the same successful integration and uptake of new change without the simultaneous assessments by both the providers at the bedside, and that includes nurses, techs, docs, and everyone in between, to then the IT folk to understand their challenges as it happens, and not be told in a report later on to come up with their own solution, but these feasibility assessments that are happening in real time. And that the skill sets, I think, that it is this recognition that yes, there's this ideal that we have, but if you can not, it's like the the teams that are able to say, all right, we know what we wish it would be like, but it's not that way. So let's acknowledge reality and come up with the best solution that is our interim step, and to set achievable goals that are not grand slams with out the door, but actually just interval improvements that get you to the next step. I think that's so imperative. I mean, I think that when we going back to the question about like what was our goals, the administration wanted us, was pushing for hit every metric and hit them all from the beginning to make that requirement. And I think that the response back from our teams was, we don't even know how many people are going to have this, and let's be careful. And can we just try to understand the burden and the process before we start, dictating exactly what happens at each step. And I think it's such an imperative to incorporate the input from your providers, the actual people taking care of these patients, in addition to it. So I think that being, if you will, patient, like with the process, but requiring, specific, goals that are achieved at milestones to get you to a final endpoint are imperative. And I think that having multi-stakeholder skill sets at the table collectively is, in my opinion, the only way you get success here. Because if you have, they generate a report that an IT person reads later, there's no way that interaction is the same as if they did it and had a conversation, in person.
Well, great. Well, listen, I think to our audience, thank you for bearing with us on some of these audio issues, and we'll make sure next time that we'll have as clear an audio as possible. We'll also have Dr. Jeanne Huddleston will deliver her 10-minute introduction and tie the mortality reviews experience they've had with their collaborative to the sepsis topics. I, for one, just have to thank you so much for a wonderful presentation. As one of our folks that commented in the questions said, this is one of the most comprehensive sort of presentations on this topic that we've seen, and we are so grateful. What a critical issue. Thank you for your fantastic work, Ryan, and we really would love to have you come back and help us with this, because we know that this is of great interest. We had over 700 organizations who signed up for this webinar, and so we'll continue with 2 more parts to this topic. But Ryan, thank you so much. God bless you for your work, and I think we'll close this webinar for now, and then in the online version we'll have a patient advocate on. We also had folks with illness. It's striking all over the country right now, and we had people out, but we will go ahead and close, and it's my honor to close this webinar. And thank you, Ryan, for a great job.
Thank you all.
Bye-bye.
Bye.